Good evening, doctors. My name is Ankur Gautam, and on the behalf of FDC and MedTalks, I welcome you all to yet another episode of Season 3 of Diabetes Essentials with Dr. Sanjay Kalra. Today's topic is very interesting topic, taking care of renal issues in diabetes. For this, Dr. Sanjay Kalra will enlighten us. Today's session is brought to you by your zero calorie hydration partner in Result Zero. Now, before moving forward, I would like to announce the last week winners. The list is yet again long, and I'm very happy that more number of doctors are taking part in our quiz. The winners are that Dr. Vinay Desai from Thane, Dr. Vijay Agrawal from Pune, Dr. Rajiv Handa from Delhi, Dr. Bharat Praveen Mitakota from Surat, Dr. Gangadhar Rath from Bhubaneswar, Dr. Farid Khimani from Mumbai, Dr. Ashutosh Das from Tamluk, Dr. Shantanu Kumar Bhattacharya from Kolkata, Dr. Pradeep Patro from Chhatarpur, Dr. Ramesh Hegde from Bangalore, Dr. Satish Kumar Jain from Bangalore, Dr. Pradeep Pathade from Vashi, Dr. Shashi Khare from Bhopal, Dr. Lakshmipati Bhupati from Vellore, Dr. Ashwini Kumar from Kanpur, Dr. Sanjay Shiroha from Surat, Dr. Geeta Gurnani from Delhi, Dr. Manu Sharma from South Delhi, Dr. Ravi Bhatt from Sirsi, Dr. Sanjeev Puri from Hoshiarpur, and Dr. Sumita Sharma from New Delhi. Thank you all the doctors to taking part in our quiz. Now, I would like to welcome our host, Dr. Sanjay Kalra, to give his views and his knowledge on the today's topic, taking care of renal issues in diabetes. Thank you, sir.
Thank you, Ankur, and warm welcome to everyone. Now, in this journey of diabetes essentials, learning about diabetes, we are trying to cover each and every complaint or concern that the patient may present with, each and every organ system of the body. One of the most important organ systems is the kidneys. Both of them, left and right, are equally important. But have you ever realized that the kidneys have always been considered a poor cousin? A poor cousin of what? These days, I mean, not these days, but until a few years ago, the kidneys were considered a poor cousin of the heart. When we would speak of vascular complications, everyone would speak of macrovascular health, heart issues, cerebrovascular issues, and kidney discussion would be relegated to second line importance. But it's not just these days that the kidney has had to face discrimination in healthcare. If you go back to Aristotle, Aristotle felt that it is the urinary bladder which is the main excretory system or the main excretory organ. And he thought that the kidneys are just appendages along with the bladder. So the bladder was given prime importance. The kidneys were considered a bit inferior. In Ayurvedic medicine also, the bladder is considered one of the three most important organs of the body, not the kidneys. But then let's put things straight. If you go to the Bible, what you see is that the word kidney is used in multiple places. The translation is rein, Rein, and in the Bible, multiple times they speak about the importance of the kidneys. It was not thought that the kidneys are an excretory organ. Actually, they used to think that the kidneys are a seat of soul, the seat of the philosophy. So we'll come to our discussion, our presentation in a few minutes. But what I want to put in place in perspective is that the kidneys are very important. However, they have not got their due. Why is it that they never got their due importance? Maybe we were not able to measure kidney function. Maybe we did not know the impact of kidney function on health and disease. But now we do. And therefore, today we'll be speaking about renal issues in diabetes. And when we speak of renal issues in diabetes, we have to learn how to take care of them. The renal pentad tells us what all we have to take care of. For a person with diabetes and kidney disease, there may be multiple concerns. The first is maintenance of renal function. Renal function is measured in two ways, as EGFR, estimated glomerular filtration rate, and also as albuminuria. Now, because of advances in diagnostics, we can check microalbuminuria, and we can also check UACR, urine albumin creatinine ratio. UACR can be checked in the lab. It can also be checked by what we call POC, point of care testing. And this is what we advocate. Every healthcare provider should have a point of care testing machine in his or her OPD in the chamber so that you can check for UHGFR, UACR immediately. So, first angle of the renal pentad is renal function. Along with that, patient may have other concerns. In chronic health, in chronic disease, chronic kidney disease, you worry about iron status. Hemoglobin should not be too much, it should not be too low. In kidney disease, ideally the HB should be kept at 10.5. A very high hemoglobin is associated with adverse outcomes. A very low hemoglobin is also associated with adverse outcomes. Bone mineral health is important. If you don't manage properly, patient will end up in renal osteodystrophy. So we have to make sure that vitamin D and calcium are well maintained. Now, these are aspects of concern for everyone in chronic kidney disease, but sometimes we can get acute on chronic kidney disease. And the acute concerns will be dyselectrolytemia, low sodium, high sodium, usually low sodium, high potassium, usually high in kidney disease. So we worry about hyperkalemia and hyponatremia. Other acute illnesses may be acute urinary tract infection or urinary tract obstruction. And if you have an infection or obstruction, this is a cause of worsening kidney function. This is known as a post-renal dysfunction. If the patient is dehydrated, we just spoke of dyselectrolytemia, we should speak about dehydration or hydration status here. If the patient is dehydrated, that is a pre-renal cause of acute kidney injury. So the renal pentad so far, we have shared 3 points: renal function, acute health concerns, chronic health concerns. Along with that, we have to look for diabetes control because our theme here is diabetes management. And in chronic kidney disease, we have to control glucose, control hyperglycemia without causing hypoglycemia. Without causing hypoglycemia. So it's a double-edged sword. You have to walk the middle path. Just like for iron, we wanted good hemoglobin, but not too much, not too little. Along with diabetes and kidney disease, the patient may have other comorbid conditions. So blood pressure, lipids, obesity, these are issues that we must look at. So this in a nutshell is the renal pentad. One of our experts from New Delhi, Dr. Khullar, Dinesh Khullar, who is HOD at Max Hospital in Saket, New Delhi, has added a sixth point to this. He calls it the renal sixer. And the sixth point is preparing the patient for kidney replacement therapy. So you have to begin preparing the patient for replacement therapy, whether it is dialysis or kidney transplant, and that has to be done in a timely manner. So the renal sixer, as postulated by Dr. Khullar, measure, monitor, and maintain renal function. Avoid acute health concerns. Care for chronic health concerns. Be dynamic in terms of diabetes control, and also make sure that you control comorbid conditions properly. So much work for us to do. Let's try to make it simple. The first is you screen everyone. If we are able to diagnose diabetic kidney disease in a timely manner, things become easier for us and for our patients. So annually, everybody with type 2 diabetes should undergo urine albumin creatinine ratio. If not available, microalbumin. If not available, urinary albumin. And EGFR. Don't rely only on serum creatinine. Do an EGFR because glomerular filtration rate depends not only upon the serum creatinine level, but also upon age, gender, ethnicity. Now, these reports can be quite variable because of variation in diet, exercise, hydration. So therefore, there's no harm in doing the test twice. If the urine albumin is high or the EGFR is low, then you can monitor more frequently, even twice a year, thrice a year. And if you anticipate or suspect changes in these values because of changes in therapy or changes in overall medical status, you might want to monitor even more frequently. So let's remind ourselves, urine albumin, UACR, and EGFR annually in everyone with type 2 diabetes from time of diagnosis. In persons with type 1 diabetes, 5 years after the onset of diabetes, you begin screening, irrespective of age. Based upon the presence of albuminuria and reduced EGFR, or either of them, in the absence of other symptoms or signs of primary causes, we can diagnose diabetic kidney disease. However, if the patient has an active urinary sediment means that there are RBCs, casts, crystals, there's hematuria in the urine, then that is a sign, that is a marker that there may be a non diabetic cause. Rapidly increasing albuminuria or nephrotic syndrome is another sign that you should look for a non diabetic cause. If the EGFR is falling very rapidly, there may be a different cause, there may be two causes. And then there is something known as renal-retinal dissociation. Now, renal disease is also microvascular, retinal disease is microvascular. So, usually both occur together. If the retina is perfectly healthy, then there may be a different cause of kidney disease. In such patients, those with an active urinary sediment, worsening albuminuria, rapidly worsening kidney function, absence of retinopathy, absence of hypertension or very, very high blood pressure, it's a good idea to refer to the nephrologist, and kidney biopsy may be indicated. Now, we've repeatedly said that we should check for albuminuria and EGFR both. What is the reason? The reason is this heat map. Heat map tells us what is the heat, what is the risk of cardiovascular disease, the risk of poor outcomes. So you see that if you look only at the EGFR, see going from G1, grade 1 or GFR category 1 to G5, EGFR is going down from 90 and above to 15 and below. If you look at this, you find that you move from green to yellow to orange to red. So there is worsening of the heat map, there is increased heat, increased risk. The worse the EGFR, the worse the outcomes. But if you look only at the first column, green, yellow, orange, red, then you miss the fact that there are two more columns where we have orange or yellow, even for G1 and G2 patients. What is this? This tells us that if your patient has got normal EGFR but has got albuminuria, the patient is at high risk. And if the patient has got even mildly or moderately reduced EGFR, that is G3A 45 to 59, and the patient has got albuminuria, then the patient can become very high risk also. So look at the heat map again. You have to check both albuminuria and EGFR. If both are normal, only then is the patient in stage 1 and safe. If the patient has got even mild albuminuria at any point of EGFR, you have to treat. And some of the patients you may have to refer. The worse the EGFR, the more the need to refer in a timely manner. The more the albuminuria, the more the need to refer in a timely manner. But then you don't have to refer everyone. You can always prevent kidney disease, right? So primordial prevention means that you prevent diabetes. Primary prevention means we give good BP control with ACE inhibitor, give good glucose control, and prevent microalbuminuria. Suppose microalbuminuria occurred in spite of our best efforts, even then we can do secondary prevention. How will we do this? Give tighter BP control, give finrenone, which is a new drug. It is a mineralocorticoid receptor antagonist. But if even that doesn't work, diabetic nephropathy comes in, you continue the same drugs, ACE inhibitor or ARB, BP control, finrenone, glucose control, and try to prevent complications. So, as healthcare providers, we have a very important role to play. What treatment will we give to our patients? Everybody will get diet and exercise, blood pressure, blood glucose, and lipid lowering therapy. Everyone with CKD should get a statin, irrespective of cholesterol levels. Everyone with CKD should get ACE inhibitor or ARB until and unless contraindicated or not tolerated. A diuretic may be indicated. People with CKD will usually need 2 or 3 drugs for BP control. Single drug will not control them, usually. Good glucose control is indicated. Use insulin if you are uncertain. Another drug you can use at any EGFR is linagliptin, 5 milligram OD, that is safe for use. And finrenone, MRA, is something that should be added to anybody with impaired EGFR up till 25, or that is above 25, or albuminuria, even microalbuminuria. So, good glucose control, good blood pressure control using ACE inhibitor or ARB and combination, lipid control with statin, irrespective of baseline level, and finerenone. Another basic treatment would be hypoglycemic drugs. So, for kidney protection, of course, if the patient has got very severe kidney disease, stage 5, 4, then insulin and linagliptin are the best. Otherwise, in most patients up till EGFR 15, you can use GLP-1RA and SGLT2 inhibitors. They have got a renoprotective as well as cardioprotective effect. If your patient is doing well, eating well, GPLP-1RA, SGLT2 inhibitors are indicated. If your patient is frail, not eating properly, not absorbing properly, already malnourished, then it would not be a good idea to give GLP-1RA or SGLT2 inhibitor or metformin. Other drugs are available which are being studied, and basically a comprehensive approach is required. So like we said, step one, primary treatment, you treat with everything, give ACE inhibitor ARB, and as long as your patient is able to eat properly, is well maintained in terms of health, GLP-1RA and SGLT2 inhibitor will be helpful. If the patient does not respond, albuminuria doesn't respond, then finerenone can be used. This is approved by the FDA, approved in India as well. And if nothing works, then finally we will need kidney replacement therapy, which is dialysis or kidney transplant. Do remember to target an HbA1c as low as possible without causing hypoglycemia. Use SGLT2 inhibitors as long as there is no UTI, no active urinary tract infection, no active genital tract infection, no melanocystitis or pruritus fulvae. Aim for a BP 130 by 90. ACE inhibitor ARB will be needed, and one or two more drugs will be needed. Usually amlodipine or diuretics are what we add, or both of them. Anything that you are confused with, do not forget to refer to the nephrologist. If the patient is high risk or there is an abnormality that you are not used to seeing earlier, patient is worsening rapidly, please refer. But don't refer everyone as well. Be the gatekeeper for renal health. And these two questions will tell us how easy it is actually. You remember the renal pentad, renal function, albuminuria, EGFR. Acute concerns, hydration, electrolytes, UTI, UT obstruction. Chronic concerns, iron and bone health. Diabetes care, no hypoglycemia, no hyperglycemia. And comorbid conditions, blood pressure and lipids. Now remember that renal pentad and answer this question. Which is most important for renal protection? Most important. Is it BP control, glucose control, lipid control, or all of the above? Let's repeat. Which is most important for protecting our kidneys? A. Controlling blood pressure. B. Controlling glucose. C. Controlling lipids. D. All of the above. Let's move on to our second quiz question. Which is the drug of choice for controlling blood pressure and achieving renal protection, both together? Is it low sodium diet, ACE inhibitor ARB, clonidine, or amlodipine? Let me repeat again. Which is the drug of choice to control blood pressure and renal and protect the kidney? A. Low sodium diet. B. ACE inhibitor ARB. C. Clonidine. D. Amlodipine. With these questions, we look forward to questions and comments. We'll take them next week. But I would like to remind you that when we are managing kidney disease, do remember to focus on the simple things. Hydration is one very important thing, and this is especially important during the summer months. So make sure your patients are well hydrated. They'll say, how do I know? So the answer is look at the urine color. If the urine becomes high colored, dark colored, it means there is something wrong. So drink extra water. If you have diabetes, if the patient has diabetes, take a 0-calorie drink, and then the urine color should come down. Urine output should revert to normal. If it doesn't revert, please show a doctor immediately. So with these words, I'd like to thank you for being with us today. It's a pleasure being part of Diabetes Essentials. Now, these are summer months, and in summer we have many complications, many comorbid conditions. Remember, in the renal pentad also, we spoke about acute health concerns. So we have a surprise coming up for us. So the next 6 weeks. And that's the surprise, managing tropical fever. But let Ankur break the surprise for us. Ankur, welcome back. The stage is yours. What surprise do we have for all our colleagues?
Thank you so much, sir. Thank you so much for enlightening us and making us smarter every day. So, doctors and our audiences, that as monsoon season has taken the whole India into our grasp, so we want to raise awareness about a group of serious medical conditions named tropical fever. This is a disease which affect millions of people worldwide, and particularly in the tropical and subtropical region like India. And tropical fever is caused by the variety of viruses and bacteria, which can present symptoms like fever, headache, muscle ache, and fatigue. And in some cases, it can lead to serious medical conditions like organ failure and death. So for the most common topical fevers in India, dengue fever, rickettsial fever, malaria, typhoid fever, leptospirosis, influenza, acute encephalitis, including Japanese encephalitis. So for that, we have planned 6 lecture series for especially for managing topical fever in India. So we are starting our topical fever in India episode, the 6 lectures from 6th of August. So on 6th of August, that we have topic acute topical fever, which would be taken by Dr. Suneet Verma from Panchkula. On 13 August, that we have nursing and home care in fever by Dr. Sanjay Kalra. We on 20th of August, that we have topical fever with rashes by Dr. Paritosh Baghel from Mumbai. On 27th August, that we have rational use of diagnosis in fever by Dr. Sanjay Kalra. On 3rd of September, or that we have topical fever with systemic involvement by Dr. Sandeep Suri from Hisar. On 10th of September, that we have rational use of antimicrobials in fever by Dr. Navneet Agarwal from Gwalior. So, doctors, that this is the very high season for talking about such serious condition like topical fevers, and I hope that you guys will all get some information from all our esteemed faculties. So I hope that you all guys that attend our program. So thank you so much.
Thank you and Jai Hind.
Jai Hind.